Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is ready. Just sign here. I used to believe that too, until I started counting. Counting the patients who went in for routine procedures and came out permanently changed. Not better, changed. A man who walked in with back pain and left unable to walk at all. A woman who survived open-heart surgery but lost 6 months of her life to complications nobody warned her about. Here's what nobody tells you. The older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. My name is Dr. Adrian Calloway, and I host this channel, Dr. Adrian Calloway Vertical Bar Advanced Health, where every week we dig into the real, unfiltered truth about staying strong, sharp, and independent as you age. Today, I'm going to walk you through 5 surgeries that carry serious hidden risks for people over 60, and more importantly, exactly what to do about it. Now let me stop for a second, because I suspect I'm talking to someone who has either faced one of these decisions already, or is watching this because a parent, a spouse, or you yourself just got handed a surgical recommendation and something about it didn't sit right. Maybe you felt that specific kind of fear that comes from sitting in an office, nodding along to words like fusion or resection, while quietly wondering if you're actually allowed to ask questions. You are. That feeling in your stomach, the one that says, wait, slow down, is not paranoia. It's instinct, and by the end of this video, you're going to know exactly how to use it. Because this isn't just abstract medical trivia. This is about whether you, or someone you love, walks out of a hospital as the same person who walked in. Before we get into it, one quick thing, because it matters for everything that follows. If you're over 60, or you can feel 60 coming, and what you really want is to live longer, stronger, and healthier, with the independence to make your own choices for years to come, I've put together a simple plan based on what I tell my own patients. It's already helped thousands of people build a stronger, more resilient body. The link is on your screen. No need to write anything down. Just take a look once we're done here. And if today's video helps you, do me one small favor. Subscribe, tap that like button, and drop a comment. It genuinely helps this reach the people who need to hear it. Let me ask you something. If you take a brand new car and one with 200,000 miles on it, and run them both through the same stress test, do you expect the same result? Of course not. And yet for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery expectations, same timelines. That's starting to change, but not fast enough. Here's what actually happens inside an older body under general anesthesia. The heart has to work harder. The lungs take longer to clear the anesthetic. The kidneys slow down processing medications. And the brain, this is the part that surprises people, can become temporarily disoriented in ways that last weeks or even months. There's a real medical term for it: post-operative cognitive dysfunction. In patients over 70, it happens far more often than most people realize. Now, I want to be absolutely clear about something. Age alone is not a reason to avoid surgery. I've seen 80-year-olds bounce back faster than some 50-year-olds. Age is just a number, but frailty is not. Frailty is a real medical measurement. It means your body's reserve has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That climbs to nearly 60% past 85. So the real question isn't whether someone can survive the operation, it's whether they can survive the recovery. Those are two very different things, and that distinction matters enormously for what's coming. Surgery number 1. Open heart surgery in frail patients. Coronary artery, bypass grafting, or CABG is one of the most common major surgeries performed on older adults. The concept is simple. Your arteries are blocked, we reroute the blood flow, and for the right patient, it works beautifully. But here's what doesn't make it into the pamphlet. Open heart surgery requires stopping your heart completely. A bypass machine takes over the work of your heart and lungs while the surgeon operates. For a 60-year-old in good shape, that's manageable. For a 78-year-old with kidney disease, mild diabetes, and some cognitive decline, that machine is a serious assault on every organ at once. Research shows that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here's the number that stops people cold. Up to 15% of high-risk elderly patients don't survive the first 30 days after this surgery. So what's the alternative? Increasingly, there is one. It's called TAVR, transcatheter aortic valve implantation, a catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic, but far kinder to a body that needs kindness, not a battle. Does this mean you should refuse heart surgery? Absolutely not. It means you ask one question: am I a candidate for a less invasive approach? That single question can change everything. Surgery number 2, aggressive spinal surgery. Back pain in your 60s and 70s is nearly universal. I don't think I've met a patient over 70 who hasn't mentioned their back. And increasingly, the answer offered is spinal surgery, fusions, multi-level decompressions, hardware placed up and down the spine. Some spinal surgeries are absolutely necessary, no question. If your spinal cord is being actively compressed and you're losing bladder control or the use of your legs, that needs immediate surgical attention. But elective spinal fusion for chronic back pain in an elderly patient? The evidence here is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. And the complications weren't minor: blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion begin breaking down because the spine's mechanics have been permanently altered. What frustrates me most is the pain relief itself. Research shows that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better, but with dramatically higher risk. A colleague of mine, a brilliant spine surgeon, once told me, "Sometimes the best operation is the one you don't do." I think about that often. Have you ever been told surgery was your only option for back pain? Tell me in the comments. I genuinely want to know how common this is. Surgery number 3, major cancer resections. This is the hardest one to talk about, because when someone hears the word cancer, the instinct is immediate. Cut it out, remove it, get rid of it. I understand that completely. I'd feel the same way. But here's what years in medicine have taught me. The goal of treatment isn't just to eliminate a tumor, it's to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient works against that goal. Take the Whipple procedure, used for pancreatic cancer, one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. It can take 6 to 10 hours. In younger, healthier patients, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away within weeks from surgical complications, not from the cancer, from the operation. This is called futile surgery, and it's more common than people want to admit. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients undergoing resection experienced what's called failure to rescue, meaning a complication occurred that a weakened body simply couldn't survive. So what's worth asking your oncologist directly? If we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health status? That question opens a door many patients never even knew existed, and sometimes what's behind it is genuinely better. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are among the most successful surgeries ever developed. I say that with total confidence. For the right patient, a new hip transforms quality of life. People go from barely walking to chasing their grandchildren around the yard. But here's where it gets complicated for older adults. Elective means planned, not an emergency. You have time to think, to prepare, and to ask whether now is the right moment for your specific body. Statistics show that in patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries a significantly elevated risk of complications. Blood clots are the biggest danger. Deep vein thrombosis can travel to the lungs and become a life-threatening pulmonary embolism. Add post-operative pneumonia from lying still too long, add hospital-acquired infections, and the picture gets complicated fast. I want to be precise here, because I don't want to scare anyone away from a surgery that could genuinely help. The question isn't, should I ever have a joint replacement? It's, is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular health before elective surgery can dramatically reduce complication rates. Some hospitals now require a formal prehabilitation program before scheduling these operations for high-risk elderly patients, and that's exactly the right approach. Has your doctor ever mentioned prehabilitation to you? Most people have never even heard the word. Surgery number 5, emergency abdominal surgery. This one's different from the rest. You don't choose emergency surgery, it chooses you. A perforated bowel, a ruptured appendix, internal bleeding. These situations don't wait for a calm conversation in an office. But here's why it belongs on this list. Knowing the risks in advance changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We're talking 30 to 50% in the most severe cases. Not because surgeons lack skill, but because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, kidneys, heart, and lungs all get hit simultaneously. So what can you actually do with this? 2 things. First, don't ignore abdominal symptoms. Persistent pain, bloating, or changes in bowel habits in someone over 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies, that one habit can change everything. Second, have the conversation with your family now, not in a hospital hallway at midnight. What are your wishes if emergency surgery becomes the only option? These conversations aren't morbid. They're one of the most loving things you can do for the people who might one day be standing in that hallway. Now let's talk about what you actually do with all of this, because information without action is just anxiety. And that's the last thing I want for you. Before any major surgery, there are 4 questions every patient over 60 should ask. Write these down. First, what happens if I don't have this surgery? A good surgeon gives you an honest answer. If nothing urgent changes in the next 6 to 12 months, you have time to think, to get a second opinion, to optimize your health. Second, is there a less invasive alternative? Medicine has changed enormously. Robotic surgery, endoscopic procedures, catheter-based interventions options that didn't exist a decade ago are now common in most major hospitals. Third, what does recovery realistically look like for someone my age and health profile? Not the average patient, you, your heart, your kidneys, your medications, your living situation. And fourth, the one most people never ask, what is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you, and if they seem uncomfortable answering, that discomfort is information too. If you do decide surgery is right for you, what you do in the 2 to 4 weeks before matters enormously. Surgeons spend years mastering the procedure. Almost nobody spends 2 weeks preparing the body that has to survive it. Let's fix that. First, prehabilitation, training for an event, because that's exactly what surgery is. Eat more protein, your body rebuilds tissue with it, and most people over 60 quietly undereat it. Walk every day, even just around the block. Stronger legs and lungs going in means faster recovery coming out, and moving is what prevents blood clots and pneumonia. If you smoke, stopping even 2 weeks before surgery measurably lowers your risk of wound and lung complications. Second, have the conversation almost nobody has with your anesthesiologist. Ask for a preoperative anesthesia consultation. Bring a complete list of every medication and supplement you take, including the fish oil and the herbal sleep aid. Some interact with anesthesia in surprising ways. Ask whether a regional or spinal anesthetic, numbing just the area instead of putting your whole brain under, is an option for your procedure. For many hip and knee operations, it is, and it's often gentler on an older brain. And here's a small thing that sounds almost too simple. If you wear hearing aids or glasses, ask to keep them with you right up until you go under and get them back the moment you wake up. Patients who can see and hear when they wake up experience far less confusion. The research on hospital delirium is clear on this, and it costs nothing. Third, set up your recovery at home before the surgery, not after. Arrange your help in advance, who's driving you, who's staying with you the first few nights, where's the bed. Fewer stairs in that first week is better. Clear the rugs and cords you could trip on. Fill your prescriptions ahead of time. The first 72 hours after you get home set the tone for the entire recovery, and a body that isn't fighting a fall or a missed medication heals faster. Watch for warning signs too. Sudden confusion, fever, a calf that's swollen, hot, or painful. Any of those, you call, you don't wait. And fourth, please get a second opinion. I know it feels awkward. People worry about offending the surgeon. Let me put that worry to rest. A good surgeon expects it, welcomes it, because they'd want one for their own mother. Bring your scans and records so the second doctor is looking at the same picture. If two qualified surgeons land on two different recommendations, that's not a problem. That's information, exactly the kind you deserve before anyone picks up a scalpel. There's one more thing that might be the most useful of all: learning to read the recommendation itself. Over the years, I've noticed the way a surgery is presented tells you almost as much as the surgery does. Here are the warning signs. The first is speed, being rushed onto the schedule. If you're bleeding internally, yes, move fast. But for a planned elective operation, real urgency is rare, and a true professional knows that. The second is a single path, walking out with exactly one option and no mention of anything else. Remember, by the time you're 70, there's almost always more than one road. The third, and this one people miss completely, is that doing nothing for now is never even discussed. Watchful, careful monitoring is a legitimate medical choice for many conditions in older adults. The fourth is how your questions land. A good surgeon doesn't get defensive when you ask what they'd ask for their own family. And the fifth is a recovery that gets glossed over. You'll be back on your feet in no time is a sales line, not a recovery plan. The honest version sounds like, here's week 1, here's when you'll need help at home, here's the part that's genuinely hard. I want to say this carefully, because it matters. None of this means your surgeon is a bad person. The overwhelming majority go into medicine to help, and they work brutally hard. But the system they operate inside rewards doing procedures and runs on short appointments with no time to walk through 5 alternatives. The bias toward action usually isn't personal, it's structural, and the only thing that reliably cuts through it is an informed patient asking the questions out loud. So what does good actually look like? A good surgical conversation slows down. The surgeon draws the problem out for you, names the risks before you ask, tells you unprompted what the alternatives are and what happens if you wait. The very best of them will say, if you want a second opinion, I think that's a good idea, and here's who I'd send my own mother to. When you hear that, you've found someone you can trust. And one more small thing that does more good than almost anything else: never go to a major surgical consultation alone. Bring someone with you, a spouse, an adult child, a good friend. Here's why. The moment a patient hears a frightening word, cancer, surgery, blockage, a kind of fog comes down, and from that second on, they barely absorb another word. Afterward, in the car, they can't tell their family half of what was discussed. It's not about intelligence, it's simply what fear does to the human brain. Bring a second set of ears, someone calm who can actually listen, have them take notes, or with the doctor's permission, record the conversation so you can play it back at home. Tell them the questions you want asked beforehand, so if fog comes down for you, they can ask on your behalf. A frightened patient and a clear-headed advocate make far better decisions together than either makes alone. Before I wrap up, I want to leave you with something genuinely hopeful, because this isn't a video about fear. It's about options, and those options have never been more powerful. Minimally invasive surgery has transformed what's possible for elderly patients. Laparoscopic procedures with small incisions and camera guidance dramatically reduce recovery time. Robotic-assisted surgery allows a level of precision human hands alone can't achieve. Catheter-based cardiac interventions have opened doors for patients who never would have survived traditional surgery. And beyond surgery itself, optimized medical management, the right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that once seemed to require a knife. The body wants to heal. Sometimes our job is simply to get out of its way and give it the tools it needs. Let me tell you about a patient I'll call Gerald, 71 years old, retired engineer, sharp as a tack. He came to me after 3 different surgeons had recommended open-heart surgery for a blocked coronary artery. 3 surgeons, 3 recommendations, same answer every time. Gerald wasn't afraid of surgery. He was afraid of losing himself. He'd watched his wife go through a major operation 2 years earlier and come out confused, exhausted, never quite the same. He told me, "She went in as my wife and came out as someone I had to take care of." That sentence has stayed with me ever since. When I reviewed Gerald's full profile, his kidney function, his frailty score, his cognitive baseline, I sat down with him for a full 40 minutes and told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehabilitation, and the data for his specific profile showed comparable 5-year outcomes between the 2 approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photo of himself standing at the top of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he'd won the lottery. Here's what I need you to understand. This is the single most important thing I'll say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you have the right to ask every hard question, request every alternative, and take every day you need. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine. Let's bring it all together. 5 surgeries that carry serious hidden risks for people over 60. Open heart surgery in frail patients where less invasive alternatives now exist. Aggressive spinal fusion, where the evidence for pain relief is far weaker than most patients are told. Major cancer resections, where the goal must always be more good years of life. Elective joint replacement in severely ill patients, where timing and preparation matter as much as the surgery itself. And emergency abdominal surgery, where the best protection is catching problems early and having honest conversations with your family now. None of this means avoid all surgery. Surgery saves lives every single day. I've seen it. I've been part of it, and I'm proud of it. The message is simple. Be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and if necessary, a third. Your age is not a weakness. What question would you most want to ask your surgeon before a major operation? Tell me in the comments below. I read every one. And if this video helped you, or someone you love, think more clearly about a surgical decision. Share it. That one share might be the most important thing you do today. Take care of yourselves. Stay curious. Keep advocating for your own health. You deserve a surgeon who explains everything and a medical team that treats you as a true partner in your care. If you haven't already, subscribe to this channel, because every week we tackle exactly this kind of practical, honest health guidance you won't hear anywhere else. And one last thing, everything I've shared today is general medical information based on published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, please have a full, honest conversation with your own doctor or specialist. They know your history. They know your body. And that conversation, informed, direct, and unhurried, is exactly where good medicine begins.